Recording in process.
Well, this is my beautiful daughter, Lorelai. Just being the toughest little thing in the world. This is a story from a few years ago. Nick, you've been to my house?
No, I haven't.
I have this tiny little yard and I built a retaining wall around it. We had just gravel in it, you know, so I wanted to get the dirt in there so I could start building, you know, a little yard. And the way my street is, it's so narrow that the guy couldn't dump the dirt over the retaining wall. He had to put it like kind of on top of the retaining wall. So it ended up being like this. I had to shovel it across, like the middle of July in 2022. So I shoveled it across and it flattened it out. But then, you know, it made it even worse the next time he brought like more dirt because I needed another, you know, a bunch more. So it didn't even get close to getting in my yard. I had to shovel this over. I had to do it 3 times. I was so shocked. Yeah, because it took, I mean, I spent like the whole day. And I eventually got my brother to come over. We did three 10-yard like dumps of dirt on my little walkway, and we just shoveled and then walked it over into the little yard.
That's a lot of dirt.
To grow grass so they could play on it. It was a project. It kind of broke me physically. But then let's talk about the case here. So this was just the day after that 3rd load of dirt came in. It was July 7th. And at 4 p.m., Lorelai, she was 4 months old then. She had a bottle of milk. And that was before I went to work. I was doing the 11 p to 7 a, and she threw up, which she really hadn't done much her whole life. She'd spit up, of course, and she'd had some little URI symptoms preceding that. But, you know, one throw up, we didn't think too much of it. I did the shift, and I came home. I went to bed, and when I got home, actually, Lorelai said that in the nighttime, actually said that Lorelai had vomited again. And when I was sleeping, apparently she vomited like throughout the day. And so my wife brought her in to see the pediatrician. Pediatrician's guy that Ashley really doesn't like. I think he's a little spectrumy, and she just doesn't get along with him. But he examined her and said that, you know, it was a virus, and she looked okay. And I was back at work that night, so I was doing like a little stretch at night. And Ashley said that she's still vomiting, and then she called me like probably 2 a.m. Probably a busy shift, but I always pick up when she calls because she only calls when it's an emergency. And she said that something was really wrong with her. She wasn't acting normal. No pain or anything, but she just wasn't taking any milk, you know. So I said, bring her in. We'll take a look at her. And I was working across from another ER doctor who, I trust, who gave her a little Zofran, a little IV fluid, checked an I-stat, and she looked great. No pain, no fussing. She drank the milk, and we all went home together. So I thought that was cool. July 9th is my wife's birthday, so we were planning to have a little kind of party that day. And when I woke up from my nap after the shift, Lorelai had vomited actually a couple more times. And then Ashley said her poop looked weird. And then I was like, oh my gosh, goodness, I got to start thinking about this because it's been now like 3 days of her throwing up. And I don't think she's really kept anything down. She had a little fluid bolus in the ER. I think between the dirt and the overnight and maybe the impending birthday, I just wasn't paying good attention. Maybe that pediatrician got me out of my mind. And I realized like, I got to ultrasound this baby. It's crazy that it took me 3 days to figure that out because I've been ultrasounding Lorelai since she was the size of a peanut. This is her when she was 9 weeks old. You can see her little heart flickering there. This is with my butterfly. And this is her at 11 weeks. And then 15 weeks, she was getting bigger. When she came out, she was perfect. And then she started scratching her face, so she lost her hand privileges. This is her with those fold-over middies, so she can't scratch her face anymore. She was like a little bird when she was little. She was like 6 pounds. But then she plumped up, and she was beautiful. And this is her at 4 months, right before she started throwing up all that. And I said, well, this is the day, actually, I decided I got to ultrasound her, you know, for the first time outside of her mom. So what were the possibilities, you know? I think there was three things that I feel pretty comfortable finding on ultrasound. I want to talk about those 3 things, and then we'll come back to the case, if that's okay. So I guess the first one people think of is pyloric stenosis, you know, the projectile vomiting. Typically, it's a little younger, but you can have 2 to 6 weeks, up to 20 weeks. It's the most common surgical diagnosis in a vomiting infant or neonate, and it's pretty common. It's like 1 in 250 births. It does strongly predispose to the males, though. It's like a 4-to-1 male to female. Clinically, you know what that looks like. It's the non-bilious vomiting, probably projectile. You get dehydrated and malnourished with it. And the way to make the diagnosis is with the pocus baby. We can do that. So what they say is feed the baby prior and maybe during the scanning. It's one of the few exams where you do the right lateral positioning. So I don't know if that might be something they could throw up on the test for us, but right lateral positioning for this, as opposed to most other things. You want some fluid in the stomach to distend the antrum in the pyloric region, and try to soothe the baby. Probably have the mom there, maybe even holding the baby. And then you use the liver as a window, and you look across to the pylorus. Typically, it's just deep to the anterior portion of the liver, like liver tip, kind of like where you'd find the gallbladder if you were working from the other side. And a little graded compression, you should be able to find it. There's your normal pylorus and short axis. I don't know if you've ever found this by accident. Have you, Nick? Have you ultrasounded many little infant tummies yet, like or attempted this?
Not really. I haven't had.
No.
I mean, I don't have a ton of peds here, at least.
Yeah, I mean they're not. It's not a crazy hard thing to find. I think we're used to finding like the duodenum and seeing what that looks like, and so tracing back toward the pylorus is not unreasonable too. Well, the normal thing is it has these 3 muscle layers, and the typical is that they're less than 3 millimeters in thickness, and the length is less than they say between 14 and 18 millimeters, and so you can measure the muscle thickness. I think this is a pretty cool tracing. I think the muscle thickness is a little easier than the muscle length part of it. I think that tracing like a kind of a curvilinear line to get a length is a little tricky. Machines can do that, but I think that these thickness measurements are a little bit easier. I'll show you a video of it. Oh, this is why they call this the hamburger sign. This took me an hour to get this. Man, I have to give you this because this is homemade. So I made this hamburger and then I superimposed it on here. But they say it looks like a hamburger, and this is what they mean. So the middle part of that middle muscle layers, that's the meat, and the outer muscle layers are the buns. This one is actually when it's pathologic. You see the thickness here? I mean, we could probably eyeball this, but if you measure this across, this is more than 3 millimeters. Probably more than 14 millimeters long too. Can you remember pi? We're talking hamburgers and pi. So 3.14, that's probably a decent way to memorize this. So 3 millimeters thick of the muscle layer, and then 18 millimeters or 14 millimeters long. That'd be the upper limit of normal. Treatment of this? Do you know this one?
It's I forgot the name of it, but it's not they just like incise like one portion of the pylorus.
Yeah, I mean it does take an actual pediatric surgeon, which we don't have. A lot of our local joints don't have. It's a pylorotomy. It's kind of a surgical. I mean, basically what you can do here is it's got a nice temporizing feature to it, where you can actually just start hydration, IV hydration. So it's not really like the surgical emergency that some of these other ones are. The issue is it's more of a metabolic and dehydration kind of emergency. Resuscitation and then arranging for transfer to a center that can handle this is it's not as time pressing, I guess, as some of the other issues you can get intra-abdominal, because you're not talking about gut dying or, sometimes these are even managed non-surgically. They just hydrate and they support the baby until it starts to outgrow the obstruction, because they're not really complete obstructions. They're sort of relative. The next thing you can take a crack at is appendicitis. So clinical manifestations, I think, after doing medical school and 3 years of residency and now a year of a fellowship, you know how to diagnose appendicitis. But right lower quadrant pain, fever, anorexia. Diagnosis, I think, with a baby, or school-age kid, even getting towards adolescent, I think ultrasound is pretty reasonable. And we did that review course. They talked a little bit about appendicitis, but I think the advice that I would give is to start where the baby has pain, and you can sort of palpate that, or they can indicate that to you. Put the probe right where the pain is, and that's a pretty reasonable way to find that, tubular blind ending structure. The other way is to start with the landmarks. Are you aware of what the landmarks are? Do you remember what we had talked about?
Isn't that anterior inferior iliac spine?
Yeah, and then the psoas muscle, and then the vasculature there, right? That like the artery, the iliac artery. Usually, although obviously not always, you'll find the appendix sort of lying on top of that. There's like a decent kind of infographic of this. I think I'll share this with you. But you find the right psoas muscle and the iliac vessels, and they have the appendix here as this gold circle, and usually you find them between or anterior to those sort of two structures. I think we've gotten pretty used to finding the psoas muscle, the iliopsoas muscle and tendon because of the Peng block. So I feel more comfortable with this than I have probably ever. And then get it in long axis to confirm that it's basically blind ending tubular structure. It shouldn't really be easily compressible. You know the number? Everything's got a number.
I don't remember actually.
It's the outer diameter number. It's 6 millimeters. Weirdly, if you look it up, it seems like the appendix, like you would think that the appendix grows when babies grow, but the number's pretty consistent through what they recommend looking for. So like a 3-year-old would have a 6 millimeter or 7 millimeter would be abnormal, same as a 6-year-old. I mean, I would probably cheat a little bit smaller and be concerned with like a 2-year-old. You don't really have a 1-year-old with appendicitis. That's pretty rare. But I had a 2-year-old once with appendicitis. But 6 millimeters is what they recommend, sort of has the cutoff. So there's some secondary signs too. You ever found an appendix? Super satisfying if you actually find one, but very frustrating to look and not find one, because you obviously have the bowel gas problem and the discomfort problem, the wiggly baby problem. Some secondary findings too. You can find the appendicolith or the fecalith, which will be looking like a gallstone or like a kidney stone, shadows, very bright on top. You should see some free fluid and edema around. And they talk about the ring of fire, which is just increased vascularity, that hyperemia. This is a nice example that I stole, I think. Increased vascularity around this tubular non-compressible structure. Nice example of an appendicolith. This is from the Pocus Atlas. You don't need an appendicolith to get appendicitis, but certainly the presence of one would increase your suspicion and make the surgeon more interested, especially if you don't have like the rest of the clinical sort of like the white count 8 or something. But appendicolith, plus the hyperemia, and then if you make that diameter diagnosis, then you're probably well on your way. Any idea what the hell this is?
I mean, it's just like a super dilated
Yeah,
appendix with like stagnant fluid almost.
it actually is. Yeah, and I think that this one has ruptured too. I think this is an image that we got there's like a rupture too. I wouldn't probably rely on ultrasound to definitively say that an appendix was ruptured, but like on the fan through of this, they can find some free fluid that would be suspicious for rupture. One of my attendings when I was a resident was like, his kid seemed to have appendicitis, and he decided to wait and go to a place where he felt like they'd be good at diagnosing appendicitis with ultrasound. And by the time they got there, the baby ruptured. And so the baby ended up having like 3 CTs over the course of the next few months because he was trying to avoid the 1 CT. Cautionary tale. I mean, it's probably a good advertisement for getting good at doing this pocus, or like having, ultrasonographers who are pretty competent. But he was really frustrated with himself for making that call. Here's a nice example of long axis of an appendicitis. Non-compressible, dilated, blind ending. You can see on the right side there, blind ending. This one's got a lot of free fluid. I'd be worried about this one having ruptured. You can see loops of bowel on the left there, surrounded by free fluid. Large appendix, non-compressible. Pretty good test characteristics if you can find it. And you're not going to know until you try. I got the guts to do this with my buddy Jake in residency. He found a couple, and I was like, you know what, damn it, Jake can do it, I can do it. Turns out Jake's much better at ultrasound than I am, just in general. But he can do it, and I kind of can do it, and I think it's worth trying to do. This is from pocus literature. Treatment for that. This is board's review. How do you treat appendicitis?
Surgical, or if you're really, depending on
European.
Yeah, could be just antibiotics and observe, but surgery, I feel like everywhere around here.
Pretty much, yeah. Pretty much everywhere around here, surgery. Unless the surgeon doesn't believe it's appendicitis and they're just humoring you and they're like, okay, we'll start antibiotics and watch the baby. But yeah, pretty much always the idea is take it out. Really just because, not because antibiotics don't work, they do for simple appendicitis, but you just have an unacceptably high risk of recurrence of appendicitis, and you don't know when it recurs if you're going to be, how you're going to be, where you're going to be. So it's a good idea to just take it out. The last thing I would feel comfortable diagnosing is intussusception. Do you have a beat on the demos here, like what the typical presentation is? I guess I'll tell you, it's like between 6 and 36 months. Can happen a little bit earlier. The peak incidence is like 10 months or like maybe around a year. And this one also predominantly is males, like 3 to 2. And fairly common, maybe 30 per 100,000 years of life. So it's something you will run into. I've seen it a couple times. The pathophys is kind of crazy, that the intestine can start to swallow itself. Typically, the way that this happens, and this is an ileocolic, the most common form of intussusception, although there are ileo and colic and sort of different iterations of this. But typically what happens is there's some adenopathy, or in adults you worry about malignancy, that creates this little goober, this little lead point that the colon or the bowel starts to grab and then starts to suck through, and it telescopes. And of course, this becomes inflamed and obstructed, and it can become ischemic and perforate. This ileocolic is like 90% of them are going to be ileocolic. Some of the ileo are managed, I don't know if you know this, but they're actually managed conservatively. These ileocolics tend to need something. What's the manifestation of this? How does this look classically?
It's like the sudden pain. Sometimes can get like improved with like, I don't know what to say straining, but like it can just like randomly improved in like not intussuscept.
Yeah, I think you're right. It's
Yeah.
that sort of colicky, like intervals of pain. 15 to 20 minute intervals of pain. You know, they describe the vomiting because it is an obstructive process.
Yeah.
I don't think you can really feel this. Maybe you can convince yourself you can feel this after you know the diagnosis, but I don't think you can like definitively say. How can you tell the difference between that and just like poop, or like maybe some old-timey clinician would claim to be able to do this, or to feel the olive of the pyloric stenosis. I doubt that. Yeah. But yeah, colicky, intermittent pain with vomiting. And then I've never even purchased current jelly. I don't even know if they have it at my grocery store, but current jelly stools, I guess I imagine just like really dark, kind of bloody stools. I think that's what they're describing. I do like currents though. They're kind of exotic. This classic triad, is this common, do you think? the pain, the vomiting, the current jelly stools?
No.
Like 85% of patients don't have that, I would say. Uncommon. How do you diagnose this?
Use ultrasound or CT if needed, but ultrasound.
Yeah. A lot of times in adults we find it on CT because it's not high up on a differential. But if you think of it in kids, you'll typically start with the ultrasound. And it's actually a relatively easy diagnosis to make. The sensitivity, specificity both approach 100%. And there's different ways to approach it. We did a review course and they talked about the lawnmower technique. This is me. I wanted to have my other daughter featured in this. So this is me ultrasound lawnmowering her abdomen, going to kind of right lower, suprapubic right lower, and then coming up, and then turning the probe coming across, kind of following her colon to start off, trace the colon, and then I can come back around. The reason I started suprapubic is because I got the bladder and transverse. That's kind of a good home base for me, and then I can move laterally, find the iliac vessels, slide up along the colon, and then the ascending, and then go along the transverse.
Mm-hmm.
As long as you know kind of like, the real estate that you're covering, I don't think you get lost or mixed up. The intestine can get a little mixy because there's so much shadowing all the time, but the structures in there, like the stuff, and we're really comfortable with some of it, like the bladder. We're champs with that, and we know about the inguinal crease. And so I think if you stick to the landmarks, and just realize that, okay, I can trace the colon. I can probably find the ileocolic intussusception if I trace the colon. And what you're looking for, this is me doing it. So I started, showing, for some reason this is actually playing backwards, but started the bladder and then move laterally towards the iliopsoas. This is actually little Cecilia's bladder that day, and there's the iliopsoas muscle. And this is what you're looking for. They call it the target sign. Alternately, they'll call it the pseudo-kidney sign. And there's nothing, maybe it looks a little like a kidney. Maybe it does, but not really. Not if you know what a kidney really looks like. There's nothing else that really quite looks like this in the body. So I think finding a target like this, or this more sort of longitudinal invagination, is a pretty obvious thing. It kind of jumps out at you. Do you know the treatment for this thing?
Yeah, air enema.
Yeah, the air enema. Yeah. Because air enema is usually the fix, but there's a risk there. They're insufflating with a decent amount of pressure.
Mm-hmm.
They can cause perforation, and so that's why. So who does this?
It's supposed to be a general surgeon doing the air enema.
Right. So it's actually the general surgeon needs to be available, but the radiologist does it. Like just any radiologist, not even interventional radiologist, just like I guess Zhang, if he worked at a center that had, Nancy, one of these other, like our kind of regular radiologists, they do this procedure because they do it under fluoroscopy, and they're sort of the experts in interpreting an intestinal fluoroscopy, I guess. So they do it, but surgery has to be available. That's why they can't do it at the smaller places like Vassar, because you need a pediatric general surgeon available.
Mm-hmm.
And air enema is sort of for stable patients. In unstable patients, I think, you maybe start more with the resuscitation, stabilize, and then possibly just go right to the OR. A lot of the patients, can have perforated or have to be peritoneal. So, yeah, it ends up being kind of a scary diagnosis. This is what it looks like when they're doing the air enema. So they have it under fluoroscopy. They're sort of insufflating, and then they really start putting a lot of pressure. Go all the way around, and there's the intussusception there, and now it's starting to get pushed down. You see that in the sort of bound towards the bottom left. They're pushing it. A lot of air, a lot of pressure, and bang. Now it really starts to reduce. There's still pressure. There it goes. You see that? How it flipped. They really had to really fill that colon up, though. You start at the rectum, fill it all the way up, goes all the way up the descending, all the way back to transverse, all the way down the ascending, and starts to push on that ileocolic intussusception. So it's a decent amount of pressure. It's not something you can do at home. Dispo for this patient, say this patient came into an ER you're working at where they have a general surgeon, you have the radiologist do this. Radiologists don't admit kids. What do you do with the kid who just had his or her intussusception reduced?
Assume they would be admitted then.
Often they actually just observe them. Mm-hmm. Maybe like a 4-6 hour observation in the ED, depending on whether they're very dehydrated or how sick they are. They can take PO and they've been successfully reduced. It's possible for them to recur, and there's some places that say maybe 20% of kids do recur, but they don't really need to stay in the hospital unless they're otherwise sick. So actually, this is a potential discharge from the ED after they take some take some milk or take some crackers and look a little bit better. You just have to counsel parents that, because 1 in 5 recur, and because most of those recurrences happen within 72 hours, you just got to kind of watch them to make sure that they don't sort of have the same symptoms recur. So why choose POCUS for any of these three? They're all time-sensitive diagnoses. I think the sooner you get the diagnosis, the sooner you can initiate our treatment, or a lot of times in our case, the transfer for the patient. Depending on where you end up working, ultimately, I think that it's possible you're going to be the best sonographer in the hospital. And so I think your skills are probably, for kids especially, they're probably going to be better than your regular sonographer just coming through who does mostly adult gallbladders and kidneys and DVT studies all day. I think incorporating POCUS into your physical exam with kids is probably the way to go, just kind of get it all done. And the kid is probably going to, just because of the rapport you can generate, probably going to trust you more than the ultrasound technician. I think there's probably a lot of reasons why you would choose to do this point of care rather than waiting for the ultrasonographer to do it. And you can always get a confirmatory afterwards, but the combination of you having the skill, you incorporating into the physical exam and the time-sensitive nature with all three of these, I think I would just go POCUS first every time. I'll give you some hot tips here. So hot tip number 1, be systematic with the scanning. Use the linear probe, obviously. I think if you're starting to dig around with a curvilinear probe to find structures, you're probably not going to find what you're looking for. Try to warm the gel. I do keep a gel packet in my back pocket for sensitive people throughout the shift. Turns out if you put 2 gel pockets in the same back pocket and you sit on them, they explode. So just one gel packet per pocket is what I would recommend with that and practice. Did you know that if you put 2 gel packets in one pocket, they explode?
I am hesitant to put them in my back pocket, specifically for that reason.
It depends how squishy your butt is, but I can sit on one gel packet and not explode it. Right. I guess I could put it in my side pocket.
That's what I always do. Or my little the jacket pocket. That doesn't warm them up that well though.
Yeah, it needed to be warm. Yeah. But just because you're sitting on a chair, everything's just the chair and your butt, and it's stuck in there. I feel like it warms up better than if it's in your side pocket because you get the wind against your thigh. But what were we talking about? Oh, and consider these diagnoses in lethargic kids. I read some really scary cases that were published of babies who were just presented lethargic. They thought that they were septic, and there was one where they were doing an LP on a baby who they thought was meningitis, and they were resuscitating. And during the LP, they had this current jelly kind of stool, and they said, "Oh shit, this is intussusception." So it can be kind of subtle and sneaky. All right, let's go back to the case. So I finally came to my senses, and I put the butterfly on my darling little Lorelei. And the first thing I noticed was that she had obstruction, right? I don't get to the chase here, but there's some reverse peristalsis. This is her dilated small bowel, kind of to and fro contents, and then around it there was free fluid. There was quite a bit of free fluid. So then I scanned around a little bit, and I found that she had this. She had a little target sign in the right upper quadrant. And so I look at all that free fluid she had too. So I took a bunch of pictures that day. I should have taken more. I wasn't thinking that I'd end up. I really wasn't thinking at that point. But I remember I turned to Ashley and I said, "Okay, well, she has an intussusception." I said, "Don't look it up." I put her in the car. Walked past my dirt pile. I put her in my car. And we drove down to Westchester. And this picture had to be spirited out of Westchester by Jeff Darko. He took pictures. I had to look up my daughter's chart and take pictures of it. But she sat on my lap while they did it. Basically, I went to the triage lady and I said, "Yeah, she's had intermittent abdominal pain, and she's been throwing up, and she's had these dark stools that look like jelly." And I had her put that in the triage note. And then from the triage note, the ER doctor who ordered stuff, for kids in the lobby ordered an ultrasound by the time. So that happened really quick. I didn't want to go in and be like, "She has intussusception. Let me see the doctor." I just wanted the right test to get ordered so that it could happen. when I got back to the doctor, I said, yeah, I know, I saw. What can we do about it? So this is the transverse, and then here's the long axis, and you could see she was really legit. When we were doing the other day, when we were doing our review course, there was a question asked afterwards. They said, well, why, if it's an ileocolic, since the ilium and the colic, that junction is down the right lower quadrant. Why do you look in the right upper quadrant? Why do you find it there? And nobody had a good answer, but I know the answer. And the reason is that it gets pulled up into the right upper quadrant, right? Because the hepatic flexure is sort of tethered there. The small intestine gets pulled up. It's invaginating in, so it gets pulled up into the right upper quadrant. And that's why you start in the right lower quadrant, but you slide up right under the liver is where you find the thing. That's why. I don't know why they didn't just have that locked and loaded. I guess maybe you haven't totally wrapped your head around this unless your daughter has had it. This is the free fluid in your abdomen.
Yeah.
So I kind of fucked this one up because it had been, I guess, just 3 straight days of her having this intussusception on the heels of having like a little viral URI. And she was so dry. But she's such a happy little kid, you couldn't tell. I couldn't tell when we brought her into the ER that night. She never had any pain. The other doctor was working, couldn't tell. Just did an IV with some fluids because they thought it was like a little viral URI. There was never any pain. By that time, she was so dry. I don't miss ultrasound guided IVs. Julian was there. Julian? He's awesome. He's a really good nurse. I think he tried 6 times to get an IV on Lorelai and couldn't get it. And then I tried and I couldn't get it. It was the most frustrating thing. The reason we needed an IV was to start resuscitating her, and they wouldn't do the procedure until she had an IV. That's the protocol. I think we just couldn't get an IV on her. I think she was really dehydrated at that point. So I called the radiologist. He was a super nice guy, and I said, "Hey, man, I'll go with her with you. I'm an ER doctor. Can we just try? Because I think that she's really dehydrated, and I just can't get an IV on her." Kept trying and trying. He was really cool, and he did it. It was cool to see him do it. I didn't take a video of it, but here's a representative image, and it's crazy what they do. They actually put the tube right in the butt, and they tape the butt. You need to think about this. They tape the butt around the tube to get a seal, and then they inflate a little kind of catheter on the inside, so they have a seal, and then they transduce like a sphygmomanometer across it, and they inflate it, and then they do. I showed you the fluoroscopy, what that looks like, and hers was successful. And she's a little sneaky little bitch. She looked like this happy. This is literally like 5-10 minutes after the reduction, she started drinking milk again and just looked awesome. She never looked sick, man. She never had any pain. She never fussed. She was just like throwing up. She'd drink her milk and throw it up, and sneakily was getting super dehydrated. So it was a good lesson for me about the sneakiness of the diagnosis. And I've become a little gun shy. And she did seem to respond to Zofran in the ER when she went, but she threw up a couple hours later. So I'm pretty trigger happy with just checking babies these days, ultrasounding their bellies, even if I'm just doing it myself, part of the physical exam. And I'd recommend that you probably do too. I mean, tough diagnosis to make. This is her couple later that summer, and the grass had grown into my yard, and she started eating it. So I think she's fully recovered. Oh, little queen.